I open this academic ceremony in which Ms. Anufriyeva will defend her academic thesis, Perception of Quality and Satisfaction with Primary Healthcare in Ukraine. I welcome you, of course, and wish you lots of success together with your paronyms. And I also welcome your supervisors, Professor Groot, Professor Pavlova, and Dr. Chernis, and of course the members of the opposition, whom you will meet later, and of course your guests on site and online. But before we start the opposition, I give you the floor to tell us and to tell your family and friends what is the subject of your thesis.
Thank you. Dear Mr. Prorector, dear members of the Defense Committee, dear family and friends, with this presentation, I will give you the summary of my study called The Perceptions of Quality and Satisfaction with Primary Healthcare in Ukraine. Around 2015, Ukraine faced a health crisis. Almost 25 years after the country became independent, the life expectancy dropped unexpectedly. And there was the high number of inadequate treatment of non-communicable diseases. These poor health outcomes and the general perception of inadequate care were linked to shortcomings in affordability and quality of clinical care. At the same time, there was the frequent changes of governments and, for example, during the period of time from 2010 till 2016, there were 9 ministers of health in Ukraine, and each of them had his or her own agenda, which of course neither facilitated consistency in goals and practices in healthcare system, nor helped to maintain trust of the population. At the same time, due to the highly centralized top-down culture, healthcare providers also lacked managerial flexibility and performed or practiced highly paternalistic relationships with patients. I would also like to say that there is an order of Ministry of Health number 752, and it is a very important one because it seems to be the basics for understanding of quality or the basics of information about healthcare quality in Ukraine, or the main source of knowledge. At the same time, healthcare quality and quality management as disciplines are not still present in some medical educational facilities in Ukraine, programs for healthcare professionals. Although both disciplines are touched upon during the so-called CPD, or continuous professional development of healthcare professionals. At the same time, there is the lack of access to other sources of knowledge because the majority of healthcare professionals do not speak English and do not have this access to other sources of knowledge about healthcare quality. Thus, this order, the above-mentioned order, is used in the CPD programs almost as the only source of knowledge about healthcare quality term and healthcare assessment. There is the lack of evidence on both, on the perception of quality, both among healthcare managers, who are actually, which is unique for Ukraine, who are primarily medical doctors and medical nurses, and healthcare users. But a common understanding of quality among both healthcare professionals and patients in Ukraine is a first step towards a more service quality-oriented health system. Evidence on the perception is very important because the perceptions of healthcare managers help to shape the objectives of healthcare system. At the same time, users' perceptions are helpful in improving quality and also in increasing utilization of healthcare when it is needed. Thus, the central aim of my dissertation is to obtain new knowledge on the perception of healthcare quality by different stakeholders, as well as insights on self-reported satisfaction with primary healthcare, specifically on general satisfaction with primary healthcare in Ukraine. The central aim of the dissertation is approached through 4 research questions, and further on I'm going to tell you a little bit more details about the 4 studies included into the dissertation. Research question number 1. What is the available evidence on quality assessment based on the patient's opinions as well as applicability for policy making? The objective here was to systematize the evidence on the validity and reliability of subjective measurements of satisfaction with healthcare services in general, and the following results were received. Patient satisfaction is highly subjective in nature. A lot of different factors influence the choice of measurement tool, and the purpose of measurements being one of the most important. The longer the tool is in use, the more accurate it becomes. Despite the subjective nature of satisfaction, many studies underline its importance for understanding the relations between healthcare quality and healthcare utilization for health and also for healthcare decision making. The results of this systematic review provided the basics for further analysis, namely for the analysis of quality perceptions and quality assessment instruments used in Ukrainian healthcare facilities, namely primary healthcare services. And on the next slide, you see the results of the second study included into the dissertation. The research question was, what are the primary healthcare managers' perceptions of healthcare quality and quality assessment instruments used in the everyday practice of Ukrainian primary healthcare settings? As I have already told you, the primary healthcare managers in Ukraine primarily are medical doctors and nurses. They were asked to identify quality attributes, and you can see all those quality attributes on the slide, which we also subgrouped into 3 parts according to the Danabedian's model, which says that quality is equal structure plus process plus outcome. And as seen from this very slide, healthcare managers perceive quality in Ukraine mostly as process quality because, as can be seen from here, the compliance to standards constitute the highest importance for healthcare managers, 19 and 9%. So the results are the following. The respondents showed the most important for them attribute being compliance to standards. And if we take into the consideration the above-mentioned order number 752, this is actually almost the direct citation from it. Quality is equal to compliance to standards. And also from the previous side, there are a lot of opinions about quality, and I can make the conclusion that there appears to be a lack of consensus about healthcare quality given the high number of different attributes mentioned. But also I was interested in the perceptions of outpatient care quality by healthcare users. And I was also interested in comparison of perceptions between the healthcare managers and healthcare users. So on the next slide, you see the diagram on which the healthcare users in Ukraine chose the most important for them attributes. And as you see, for healthcare users, the most important attributes are effectiveness of treatment, but in the meaning of correct diagnosis and adequacy of treatment. And also the second most important is qualified medical personnel using modern and safe treatment methods. Both aspects are predisposed by socio-demographic characteristics, and both aspects are the aspects of process quality. The same process quality is also important for the healthcare managers, but the healthcare managers focus mostly on the compliance to standards. There appears to be a lack of association of such attributes as respect, trust, and empathy to the patient, and the possibility to stay close to family members of patients, as seen from the diagram. My next step was to explore the satisfaction with primary health care in Ukraine, and I had the opportunity to compare the data in dynamics starting from 2016 till 2020. So the objective of the next study was to examine general satisfaction with primary healthcare services among service users and non-users before and after the start of the healthcare financing reforms in Ukraine. I was also interested in the question if the reforms actually have the direct influence on the satisfaction with healthcare services. So the results were the following. The respondents are rather satisfied with the services of district and family doctors and pediatricians. There was also an increase in satisfaction with the district and family doctor over time observed. However, this does not seem to be due to the reform. The results for the pediatrician services were mixed. The differences were statistically significant only for 2 years out of 4, only in 2017 and 2018. I also want to show you this very table and to say that for this very study we used difference in differences method. This is a quasi-experiment, and usually it is used with the panel data, which means that the data is collected through several years with the same respondents. In my case, it was impossible. I had the cross-sectional data, though it was collected every year starting with the 16th and finishing 2020, but the respondents were not the same. Thus, I had to apply several matching techniques over time and compare non-users, use non-users as the control group. But again, I will show you the result for the pediatricians. Here you can see the 2 years of statistically significant differences. But again, in comparison with other years where we see absolutely no difference, this doesn't seem to be due to the reform. But I want to return to this question of the reform, because with healthcare financing reform, Ukraine experienced really dramatic changes. And these dramatic changes of its healthcare were not connected only to the financing principle or managerial freedom, but most importantly, it changed views and perceptions of healthcare professionals and users on healthcare system in general and on quality in particular. Yes, of course, renovations were made, new equipment installed, and free choice of the provider also became available for the patients. But most importantly, highly paternalistic approach is being changed at the moment, and both healthcare professionals and patients became more active. Quality is perceived through the most important attributes, and understanding the focus of importance is important because as it defines quality, and it also predisposes choice of assessment methods and management tools. As we saw from the presentation, both healthcare professionals and healthcare users in Ukraine focus their attention on the process. It is not unexpected because the focus of my attention was the primary care, and primary care is process-oriented in its core. But the limitation of focus on process is that it ignores quality attributes of outcome and quality attributes of structure. This means that At the policy level, health system responsiveness should be improved by raising awareness of important attributes of structure and outcome among both healthcare professionals and users as well. At the research level, I did not find other studies of health managers' perceptions in Ukraine, which means that I can perceive the findings of this very study to be the baseline of such kind. Effective healthcare services are co-produced by the healthcare provider and the patient, and satisfaction measures aspects of quality that are not measured by clinical quality management tools, aspects that are most important to the patients. This means that on the policy level, quality assessments should be also complemented by the measurements of the aspects that healthcare users truly value. Paradoxically, in Ukraine, satisfaction with primary care is high, although the health system does not perform well. The reasons behind high and increasing over time satisfaction are unclear, but seem not to be directly linked to the reform. In Ukraine, there is a tendency to express satisfaction. Healthcare patients express their satisfaction with the services they received on a facility level and enlarge that satisfaction, covering also the system. That is why that implies that at policy level, healthcare reforms should be strengthened by quality improvements in healthcare settings. And at the same time, the principles of healthcare system functioning should be well communicated to healthcare users. I thank you, and I'm giving the word back to the prorector.
Thank you, dear candidate, for a clear presentation. Then we start the opposition now, and we start with the chair of the assessment committee, that's Professor Paulus, who's a professor of economics of education and healthcare at the University of Maastricht.
Thank you, prorector. Dear Mrs. Candidate, thank you first for your dissertation. It was interesting, it was relevant, and it's a very readable piece of work. So I would really first like to congratulate you and your supervisory team with this achievement. As you can expect, I read your dissertation, so I also came across some questions. And I would like to start with some questions with respect to chapter 2. You present the results of a literature review there in chapter 2, and I have some questions with respect to the included studies and with respect to the results and the implications they have. Let me first start with the included studies. I saw that in your literature review you included studies from different regions, basically all over the world, so different countries. And in these studies, researchers use different tools to measure satisfaction with healthcare, maybe even as a proxy of quality of healthcare. And they did that for their specific contexts. So my first question is, do you think that some of the tools that were developed in completely different regions or countries would also be useful or could be used in the context of the Ukrainian healthcare system?
Highly esteemed opponent, thank you so much for your questions. Yes, I do think that some of the tools are applicable for the Ukrainian healthcare system. Doing this review, I understood that there are a lot of different tools. That is because healthcare providers want to find as precise tool as it is possible. Of course, it is impossible to use one and the same tool for every context, but these tools can be tuned and anyway used. For example, we saw that with the cervicality instrument, which is tuned for different contexts and to different cultures. So I believe that even if we are not able to use this or that tool, we can use it as the basics, add there the context of the country, and try to use this very tool in Ukrainian healthcare. If it is not good, then other tuning will be necessary. But anyway, as the basics, tools are applicable. And the systematic literature review showed high reliability of those tools, which means that if a thorough manager chooses the tool and takes care about its validity and reliability, then it can be tuned and used in different contexts.
Yeah, so you actually say it's more generic tools, which to some extent have to be made context dependent.
Yes.
Yeah, when I saw the countries that you included, I saw there were Bismarck systems, beverage systems, and Ukraine is, of course, in transition from a Shemasco system. Do you think that the healthcare system itself is also context dependent and therefore is one of the specific aspects of such a tool?
It is dependent. But again, Ukraine has a very unique situation of this transition. And the transition means that there are people who still remember the further system, the people who are bringing some new tools, the people who are creating the new system, which means that Ukraine has really a unique opportunity to tune the instruments according to the system and to tune the system to the needs of the population. Which means that the responsiveness the responsiveness of Ukrainian healthcare system has the potential to be a really good one.
And what I also noticed in chapter 2, because I understand what you say now, but one of the recommendations you say, I want to arrive at, let's say, a kind of unified standard of satisfaction measurement, actually. I'm really eager to know what do you see as the steps to develop such a unified standard? So what steps would you take?
Partially, these steps has already been taken because I work with the Ukrainian-Swiss project, and within this project we develop different educational programs. And for example, I was responsible for developing the online course on quality management. And I have this unique opportunity to communicate with doctors who are also managers, to see their state of mind, to have the influence, to show them different instruments, and together there is this opportunity to reach at least more or less unified understanding of quality. I mean more or less because now, at the moment, these understandings are like a huge variety of them. And you saw that from the slide,
exactly,
a lot of perceptions.
Yeah, I see a lot of different, because that's maybe also my last question to you is, I saw there are differences in the perceptions within the group of managers, difference in perceptions within the group of patients, but also between managers and, let's say, the healthcare users.
Exactly.
So how can you then arrive at a unified standard if these perceptions differ so much?
First of all, of course, there should be more studies and more communication between different stakeholders, because the system was really rigid and really closed, and it was like not traditional to accept points of view of other stakeholders. Now the situation is changing. And the medical community became more open and more active. They are not waiting for the order, from the above to tell them what they do. They have already they have already experienced this managerial freedom. And there is, of course, huge difference, because in Ukraine there are state facilities and private facilities. And private facilities like one step ahead, because they had the opportunity to try out different healthcare, different quality systems, I think since 2006. And now there is the unique situation of communication, when the points of view, the views started to be sharing, and they started to listen to each other, both patients and and healthcare managers.
It's good to hear that they are so proactive.
Yeah.
So
communication, education, I think those two are the basics.
Thank you very much.
Thank
I will
you.
give the word back to the rector.
Thank you, Professor Paulus, for your opposition. Then we come to the following opponent, who's also a member of the assessment committee, and that's Dr. Zastavny. and he's working at the School of Public Management in the Ukraine Catholic University in Ukraine. And thank you for coming all the way from Ukraine, albeit online. Welcome, the floor is yours.
Thank you so much. Thank you, dear candidate, for a perfect dissertation. I believe it can be and it will be of a high value to everything which is going to happen in Ukraine if we are going to talk about quality management and quality improvement of healthcare services in Ukraine. And I believe your dissertation will help a lot in that process. So thank you for that. I have a few small questions. My first question is, you are talking a lot in the dissertation about managers' perception of quality in primary healthcare, and that's a very interesting topic. So I would like to ask, what actual proposals could we make or could you make for managers, for managerial education or something like that in Ukraine in order to improve the quality? Because you are talking a lot about policy. And what could we do in the sense of management improvement? Thank you.
Dear esteemed opponent, thank you so much for your question. My first advice is to take into the consideration the subjective measures of quality, because managers usually focus on the resources, the premises, the number of stethoscopes there around their places, and so on and so forth. And sometimes, or well, not sometimes, but in the majority of the cases, unfortunately, managers are so focused that they do not listen to the patients. And the patients have their own views and own focus. And as we saw, they are also focused on the process with slight differences, but those slight differences might, change the world. So my first advice is to assess quality, not only in the measures of the number of the resources used or financial resources received and so on, but also include such subjective measure as patient satisfaction into the routine practice of healthcare managers. I believe a lot can be learned from that information and can be very helpful in tuning, probably even the services for the patients and making them more responsive. The open dialogue is crucial here.
Okay, thank you. My second question is, I would like to talk about perception of quality by patients. You are writing in your dissertation, and you probably understand that a lot of methods which are used in Ukrainian healthcare are quite, to say, out of date, probably, and old-fashioned. Let's call it old-fashioned, because we have a big thing from the Soviet Union times and so on. So do you think patients always understand the quality right? And I know that you think that probably not always, but what should be done in a big perspective in order for the patient to become a part of this network of quality, and what on the governmental even level could be done in this perspective?
Thank you so much for your question. Well, I do agree that patients do not always understand technical quality. Of course. Being a patient, I'm not a doctor, and it is impossible for me to assess and understand what's behind the medical procedures. I'm the person who receives them, but I'm not only the person who interprets them correctly. That's for sure. That's absolutely correct. But patients include into the notion of quality, into their understanding of quality, not only clinical quality. There are a lot of different factors that are included into their satisfaction. But on the other hand, satisfaction is the driving force of utilization. And of course, if the patient is not satisfied, not by clinical quality, but let's say by the surroundings or by the communication with the doctor, it will mean that the patient will not utilize your services for the second time or the third time, or will not come back to you. In this case, what can be done further? Again, open dialogue, understanding what managers mean by quality, what doctors mean by quality, what patients mean by quality, and trying to find these attributes that are most applicable to you as, for example, as the manager of healthcare center, and use them in your everyday practice. If we are not talking about the policy and going to the level of the facility, I believe this is the answer to the question.
Yeah, thank you so much. But one small clearance on that question. Do you think we should improve the clinical knowledge of the patients? Because I'm a GP, I'm trying to improve a clinical knowledge of my patients every day. How do you think would that help to perceive quality better for the patients? Thank you.
The quality by you, or I didn't understand.
Clinical knowledge. Should we improve the clinical knowledge of the patient? Should we clarify that this? Yes.
Short answer, please.
Sure. If I'm the patient, I do want to know what's going on with me. So if you're asking me as a patient, yes, clinical knowledge is at least a little bit, will be much helpful in making the decision to go on with this treatment.
Thank you so much. I'm very satisfied. Thank you.
Thank you, Dr. Zastavny, for your opposition. Then we come to the following opponent, also a member of the assessment committee. That's Professor Burger, who's also online, and he's endowed Professor of Economics of Happiness at the Open University in Heerlen. Thank you for coming from Heerlen. Professor Burger.
Thank you, Prorector. Dear candidate, I would also like to congratulate you with your very well written and interesting thesis. And my question is about the propositions in your thesis. So what you do in your thesis is you discuss objective versus subjective data in health studies and the analysis of quality of care. And at several points in your dissertation, you seem to support the idea that objective and subjective data complement each other, and you should use them in tandem to support decision-making. At the same time, you seem to advocate for the use of less subjective data in proposition 6 of your dissertation, but maybe I understood you completely wrong, but maybe your paranym can first read out proposition 6.
For your question, I will read aloud the proposition 6 for everybody to understand what we're talking about.
Yeah, your paranym can do, dear candidate.
Oh, sorry, didn't hear.
Your paranym can read out proposition 6.
Could you please
That's an official task.
Providers in healthcare would benefit of object indication of quality are used. Thank you.
Yes.
Thank you.
This very proposition is about healthcare managers who are focused on the process in Ukraine. And here I'm saying that, of course, process is wonderful, is like the core of primary healthcare management, but at the same time, taking into the account the attributes of outcome, like satisfaction, patient satisfaction, and for example, such attributes as tangibleness, which belongs to the structure. So they will be really important, and they will complement that focus on the process that our healthcare managers perceive and express.
Yeah. So as a follow-up question, So how would an ideal dashboard looks like for like these healthcare providers?
This is a very interesting question. Thank you. The ideal dashboard, I think, should start with at least these and these attributes combined. Here on the slide, you can see the attributes that belong to the structure, process, and outcome in the classical way, expressed by the managers. And on this slide, there are the attributes most important for the healthcare users. So to start this ideal board, I would probably combine these two together and also go to the policymakers and also ask them what are the most important attributes for them. And then after such study, after such research, I would be able to start the ideal dashboard. And further on with the communications with different stakeholders, we can tune this dashboard according to the Ukrainian context.
Thank you. A second question I had with regard to your thesis is that like one of the strong points in your thesis is that you study both like the primary care manager's perception and the user's perception. And what can primary care managers learn from the studies on users' perceptions, in your opinion? And a related question, if they read your studies, do you think that they will also listen to the users and incorporate some of their ideas?
Again, a very interesting question, because we had a very long time of a very rigid system. I think that if you asked this question a couple of years ago, before the start of the reform, I would say that no way. Healthcare managers would never listen to the patients because of this highly paternalistic approach. But at the moment, the situation changes and both parties are very open to listen to each other. And both parties understood, especially those doctors who started using their managerial freedom, they suddenly understood that they are on the market, and they suddenly understood that they are on the competitive market. And to be competitive, they have to use to their patients, they have to tune their services and to make them as much responsible as it is possible. Because today the patient comes and tomorrow the patient decides, no, the toilets were no good there, I will not go there. This is kind of like a very, general example, but at the same time, at the moment, yes, I believe that both parties are ready for the open dialogue. And I also can say for sure, because I was a part of different actions after the reform started, I must say that healthcare managers and policymakers, they are asking already for the researchers to give them information about different perceptions, because they would like to use it in the daily practice.
Thank you. That's a very encouraging perspective. I give the floor back to the prorector.
Thank you very much, Professor Burger, for your position. The following opponent is also a member of the assessment committee. That's Professor van der Weijden. She's professor in implementation of clinical practice guidelines in the University of Maastricht. And today she has also accepted the role of secretary of this committee, for which I'm very grateful.
Thank you, Mr. Prorector. Dear candidates, I would like to add to all the compliments that already have been given to you. It was a great, interesting read for me. Congrats with this beautiful work and it's all these impressive papers. And there's a lot that I would like to discuss with you. But let's try to work further on the debate that already is here in the room on what, if we look at the future, what would be the way to go? And you mentioned open dialogue, and that's very nice to learn that there is space now in Ukraine to have this dialogue. But there is also, you know, experience in other countries. It's in the Netherlands, it's in the UK, and indicators to measure quality have been there, are here to stay, I guess, but are administrative burden. So we have quality frameworks that have been there and have gone because there is too much administrative burden. And let's face, your work shows again that it's difficult to design the beautiful final dashboard like you just discussed. It's not an easy task to get consensus in your open dialogue. Let's try to have a look in the future. Forget about consensus in your open dialogue and be a bit more directive. Let's forget about satisfaction. Measuring is so difficult and complex and heterogeneous, and it's a burden for patients to fill in questionnaires or to respond to interviews. And let's go for PROMs. It's the patient-reported outcome measurement. How do you feel about that?
I did not touch PROMs in my dissertation, that's for sure.
No, but we are now. You like fairy tales, so we are now dreaming a bit beyond your thesis. Yeah.
Any views, any experiences expressed by the patients are precious. The thing is to make them express those opinions, views, and patient-reported outcomes.
Yeah.
This is a huge question because even if something is wrong, not every patient will report the outcomes at all. So thinking about the future and about the ideal dashboard, of course, ideal dashboard would be probably as huge as half of the world, including all those, different instruments. I don't know. I don't have the answer at the moment.
It's a difficult question. I realize that, but perhaps I can phrase it differently then. So in the Netherlands, we try to work on this, to reduce administrative burden for professionals and patients. We skipped satisfaction. It makes a difference. We try to find a PROM, which is generic.
Okay.
While you say the one and the same tool for different contexts is impossible, okay, well, the experts within the country, they have said, let's make this patient-reported outcome, which is phrased in such a way that the patient fills in a questionnaire, I reached my goal. I'm now putting it very shortly, but that's the core of this PROM. It's a generic question.
Okay.
And then there's a Likert scale, or you can even discuss what the answer categories are. But I reached my goal. So if you translate to primary care, there is a lot of chronic diseases, for example, diabetes.
Yeah.
So I want to quit smoking. That's my goal. Or I want to have improved drug compliance to prevent the insulin. Or I want help in self-management for my. These are different goals, and that's a different measurement than registering HbA1cs or glucose levels. Yeah. Should we go that way? Can you advise us?
I would like anyway to know at least a little bit details of those reaching the goal. I think that this is kind of a very, very abstract question, at least at this point for me. So I do agree that this is a wonderful instrument because it's eases the way for the managers and for the patients and keeps time and so on and so forth. But
it's short. Yeah.
Yes, it is short. But again, I would like to know a bit more details.
Okay. And you are mentioning it's abstract for me. There's my worry. So, do all patients in the Netherlands or Ukraine? Could they answer such a question? Could you elaborate on that?
Yes.
What is your worry on the abstract?
My worry is that not everybody is able to formulate the aim.
We have a proportion of patients with limited health literacy And
or
it was
even
a real worry.
word this aim, express this
And
aim.
you're the language person. Your background is on writing books, and not every person. So if we go in this way, we need to coach patients to formulate their goals, and we need shared decision making. Yeah. Okay, let's stop the fairy tale here. And thank you for this little debate. I give my word back to Mr. Prorector. Thank you.
Thank you, Professor van der Weijden, for your opposition. The following opponent is also a member of the assessment committee, and that's Dr. Zvonareva, and she's associate professor at the Department of Health Services Research at the Faculty of Health, Medicine and Life Sciences in the University of Maastricht.
Thank you, Prorector. Dear candidate, let me, as everyone else here, congratulate you on a very informative and thorough thesis, and your supervisory team too. Given the importance of your topic, healthcare quality, I'm going to invite you to reflect on a wider significance of your work on conceptualizing healthcare quality, and I will pick this conversation that has been floating around here, probably from the point where you left it off with Professor Paulus. So you very convincingly documented a wide variety of views on healthcare. You showed us that various stakeholders appreciate healthcare quality very differently. So what I'm curious about here is what to make of these differences conceptually, and how we are to think of healthcare quality, perhaps beyond Ukraine as such, in light of them. Your thesis makes strong claims with regards to unification. So there is a wide diversity, and to do something about it, we have to think, as I understand, right, the text, we have to think about healthcare quality as a unification process. So we have to unify this diversity, and then we can do something about it. But I'm wondering, given your results, would conceptualizing healthcare quality in terms of unification have some dangers too, considering that it probably would involve prioritizing some views and leaving off and disregarding some others? And if so, would there be a way of thinking about healthcare quality in a more responsive or perhaps participatory way, so that we do not try to unify this diversity using some power differentials perhaps, etc., but embrace it and allow some mutual engagement between different points and go off in this direction? Would you find it reasonable or doable?
I would. Esteemed opponent, thank you so much for your question. Yes, I would. And let me step into the fairy tale back. First of all, I think that views of healthcare managers and views of healthcare users also require one more component, which is the views of the policymakers. And having all these three at hand, and having so many contexts, so many traditions, so many different ways of receiving and giving healthcare services, let's say that there is this ideal world where we embrace diversity, and let's say there is this ideal world also, let's say there is the application. Let's work on the application, which will help us, which help healthcare user or manager, just pushing several buttons, and this application gives you the ideal hospital or the ideal, healthcare facility that has all the attributes, that practices all the attributes important for you exactly. But to make this application, there is a huge work ahead of us. First of all, we need to not only stop on these 20 or so attributes. Of course, we will have to go into deep. Of course, we will have to go into a lot of different information and interpreting this information. And of course, we will go from this unification far away first. But then there's going to be a moment when we sit, when we group, when we systematize, when we create this application, when we embrace the diversity, and when the patient, pushing several buttons, has the ideal healthcare facility in accordance with the most important attributes for him or her.
Thank you very much. I guess to continue our conversation within the permitted time, my worry here would be twofold. One is already mentioned power differentials. In this inevitable, in some way, unification process, how can we make sure that we do not unduly marginalize certain perspectives, most often belonging to patients? We hear a lot of arguments with regards to, well, no, patients may not understand something, and that's a very convenient way of saying, well, we don't really have to listen to them. That is one thing. And second is about process, right? So when you have a result of this unification, in some months or half a year, things might change. How would continual relevance of certain operationalization of healthcare quality be ensured?
But this is not only about healthcare quality, and this is not only about quality attributes. I think that in our world and in our time, everything changes, and everything changes quite quickly. The answer to your question, we can't be sure. We never can be sure. And the answer to your question is that quality is a never-ending story. Quality management is never-ending story. So step by step, we can find the instruments that are most applicable at the moment. But of course, tomorrow everything might change. So going on.
Thank you very much. I give the floor back to Prorector.
Thank you very much, Dr. Zvonareva, for your position. The following opponent is again online, and that's Dr. Richardson. And she's a honorary associate professor in the London School of Hygiene and Tropical Medicine, and it is in London, and that is in the United Kingdom. And thank you, Dr. Richardson, for coming all the way from London. The floor is yours.
Thank you very much, Prorector. And thank you, dear candidate, for this timely and valuable research. I also would like to congratulate you on a well-written and accessible dissertation, and I greatly enjoyed reading it and learning a lot more about the situation in Ukraine. So, following on from my esteemed colleague, Dr. Zvonareva, I would also like to go beyond Ukraine. In your dissertation, you talk about how financing reform changed the approach to quality assurance. And this actually has very important implications beyond Ukraine for reform sequencing when we talk about health system transformations. So my question is, do you think quality assurance has been neglected in health systems reforms in the other transition countries? Or is it a sequencing issue because the financing issues must come first? So over to you.
Opponent, thank you for your question. Of course, I believe that from policymakers' point of view, financial issues are the first, the resources issues are the first. But the thing with quality is that it is in any way included also into those financial issues, because, for example, if the National Health Service, the national payer, wants or makes the payment, then it has to have some indicators to be used for understanding if the healthcare facility is of a definite level of quality and if the National Healthcare Service is ready to pay for this very level of the services. So I believe that also in the financial issues, quality is some kind of included. But for the reform, for the sequence of the reforms, it is not only enough to change the financial principle. It must be complemented also by promoting quality issues within the country for different stakeholders, and also by including quality management into the medical, clinical even training, not leaving it just for the CPD.
Thank you very much. So just a quick follow-up question. If we're going to talk about the sequencing and the importance of including quality assurance in discussions of systems reform, my esteemed colleague asked about your advice for managers, and another esteemed colleague asked about your ideal dashboards, but I'm going to go a step higher. So I'm going to say, what would your advice be for ministers? You cite in your presentation, you talked about a national quality strategy. What are you going to put in your national quality strategy? Thank you.
That's a tough question. On the one hand, because I did not research the views of policymakers, so it's kind of a little bit uneven ground for me here. But on the other hand, if you let me, I would give the personal experience. Several years ago, long before the reform in Ukraine, during this sequence of different ministers, I had the honor to meet in the Ministry of Health the person who was responsible for the healthcare quality sector. I was honored to meet because I was invited to teach this person quality management issues, which means that the first question is the question of education. And it also concerns ministers as well. It also concerns the top managers of the country. And it also indirectly connected with this unification I was talking about in my dissertation. Because in my mind, unification means not only knowing attributes important for the different stakeholders, but unification means that there is the mutual agreement between different stakeholders about the notion of quality in the country using the definite resources and so on and so forth. Which means that, again, open dialogue is very important, but the most important thing to start with this very quality strategy is to sit down together and write down what quality in healthcare means in Ukraine, using this very time, resources, people, and so on and so forth. And then educate this understanding of quality, give this information to everybody involved. So unification means not only how you perceive quality, in what terms you perceive quality, but what might be used as unified term of quality in healthcare, in particular in Ukraine, for example.
Thank you very much. Thank you very much, dear colleague. Prorector, I give the floor back to you.
Thank you very much. Dr. Richardson, then we will see if there's time for another question from Professor Powers.
Thank you very much, Pro-Rector. I was listening to this debate, and in the last bit of the discussion, you were stating that you look at managers, you look at, let's say, the perceptions of patients, but did not include policymakers. And I was wondering, when you said that, maybe in hindsight, or maybe looking forward for a new research, would you include policymakers, but would you also include other stakeholders as well, or different types of healthcare providers, maybe?
Yes, thank you so much. That is a really interesting question. And actually, my ideal thought about my dissertation when I started was to include policy makers. Mm-hmm. But because of these changes in
You may finish your answer if you want. You may also say enough is enough.
Thank you. I will give a couple of more words about that. Well, this was my idea, to include policymakers, but the situation in the country was rapidly changing, and I wasn't able, because when I started there was one minister, when I went on there was another one, and I finished with the third one. But I do agree, and I do have the ambition to go on and to make research about the policymakers' views on quality in Ukraine, and go further into what other stakeholders there are, and whom I might use to tune the vision of quality in healthcare as exact as it is possible.
I'm looking forward to that. Thank you very much.
Thank you.
Thank you, Professor Paulus, for your position. Dear candidate, Ms. Anufriyeva, the time appointed for the defense of your thesis has passed. This degree committee will now withdraw to discuss the quality of your thesis and the way you defended it. And I request that you and your company here await the results of our deliberations and our return in the room. And I suspend the meeting.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Shine like a diamond.
Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and not. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and not. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
CV. You have written your dissertation alongside the many other activities that you're involved in. Parallel to your academic papers and your dissertation, you also wrote children fairy tales and children detective stories. You were able to do all that combined with your teaching activities, the development of online courses, and the coordinating role at the Medical Education Development Project. And perhaps even more important, you were able to be engaged in activities in completely separate worlds. Your work on patient satisfaction describes the real world, not a fairy tale. With the detective story, it has in common that it's a search for the truth, though, based on facts, not on fiction. And I again have to emphasize that it's a great achievement to write an excellent dissertation in an environment that is not used to and not always conducive for cutting-edge academic research. Of course, the Russian invasion posed another obstacle for your work. Your parents live in the eastern part of Ukraine and were affected by the invasion in 2014 already. It came closer to home with a large-scale invasion in 2022. Still, this did not set you back. Despite everything that happened, your work on your dissertation was undeterred. This focus on the things that really matter to you is, I believe, one of your strongest traits. On the other hand, you're also a connector. You care about others, and you are for everyone a light that shines. As someone said to me recently, Valentyna is a quality person. She follows the quality assurance philosophy in all layers of life. We have always seen you in a positive spirit, even when times were difficult. I still remember that we were worried when the invasion started that you would get trapped in Kiev, as you lived relatively close to one of the airports which were vulnerable to Russian attacks. You seemed to worry less and were more concerned about the impact the bombing had on others, including your dog Magnus. Eventually, you decided it was best to leave Kiev as well and to travel to Turkey, a journey which definitely was not a holiday trip, but came with considerable hazards and discomforts. The same holds for your time in Antalya in Turkey, for many people a popular holiday destination. I will leave out the details, but the holiday destination, it definitely was not for you. Finally, let me again congratulate you, Dr. Anufriyeva, with your excellent achievement, also on behalf of Milena and Tanya. I want to take the opportunity also to thank the members of the assessment committee, both here present and online, in evaluating your thesis and providing opposition here today. I also want to extend our congratulations to everyone here and to those who have taken the time to watch the live stream and will virtually celebrate this joyful event with you here today.
Thank you, Professor Groot, for this nice laudation. Dr. Anufriyeva, also on behalf of the University of Maastricht, I would like to congratulate you with this great day and with the degree you have acquired, and I hope you can really celebrate it. And I extend my congratulations, of course, to Professor Groot, Professor Pavlova and Dr. Chernish, your supervisors, and of course to family and friends here present and online. I would like to thank the members of the opposition for their work, and of course the technical support team and the PEDEL for their work, because it is always a great success to have such a hybrid academic session with guests from outside online. Having said that, I'm going to close the meeting. We have a reception over there. I have a few announcements to make. We are going to make a picture here with the three opponents on the background. Your family and friends can already go to the rafter to get something to drink. We would like, of course, the photographer to stay, and then we're going to make a picture at the stairs, and then we meet you again at the rafter for drinks at the reception. Having said that, I close the meeting.
All right, please. Recording stopped.
Oké, wil je komen al hier? Met de microfoon eventjes. De microfoon. If you come forward.
Yeah, you can say a few words to those people.
So we first make a picture.
Oh, shall I hold it for?